Hello, and welcome to episode 11 of InteropTalk, and happy holidays. I'm Dave Cassel. I'm Chief Customer Officer at Health Gorilla and former Executive Director at Carequality. Joining me today is our usual crew, starting with Dr. Stephen Lane, Chief Medical Officer at Health Gorilla, practicing family physician for going on 3 decades now, and former Director of Clinical Informatics and Interoperability at Sutter Health. We also have Jennifer Blumenthal, Director of Product for OneRecord, now a Milliman IntelliScript company, and Deven McGraw, Data Sharing Lead at Invitae, co-founder of Citizen, and former Deputy Director for Health Information Privacy at HHS. Welcome, everyone, and thank you as always. So let's start off today's episode with where we all were together, most of us anyway, at the Sequoia Project, Carequality, eHealth Exchange, Grand Extravaganza in San Diego a week or so ago. We were all, those of us in attendance, on various panels there. Jennifer, let's start with you. You were on a panel. I'll let you introduce that panel in the same way that you did it at the session, in terms of your longstanding participation in it. But you were on a panel called "The Patient is Knocking," and actually one of Devin's colleagues was on that panel as well. What would you like to share with the audience about that panel and just about the direction and that things are headed there in Carequality? And to be clear, that panel was I believe in the Carequality portion of the meeting.
I feel like I should give background to our listeners because people are listening to this across platforms and wherever they're clicking through and finding it. So to what Dave is saying, we were in attendance for the Carequality Sequoia annual meeting. And for the past 5 years, I have sat on a panel and talked about patient access, patient request, now individual access, and talking about kind of the incremental baby steps taken to empower consumers to access their data through Carequality. This panel specifically was geared towards a recent implementation guide update that says that patients that updated the implementation guide and added the addition of an IAL2 workflow and an AEL workflow with a token exchanged to secure the attributes of the verified demographics that are passed from an identity proving provider through the app or individual access service to the responding gateway. And I mean, I got on stage and I told the audience that it was going to be a little spicy, that I have been talking about the same topic for 5 years, and there hasn't been enough movement for consumers to easily query the network and get a response back for their own data. So what does that mean? That means that today there are very few implementers who were responding for if, let's say, Deven wanted to download OneRecord or sign up for Health Gorilla's individual access services and query for her own data through a service of her choice, that she would be able to get back documents, CCDAs, from the Carequality implementers. And so what the implementation guide additions asked for is essentially the certified IAL2 vendor. So that's Clear, LexisNexis, ID.me, Persona. I'm forgetting people, but anybody that you can find on the certified Kintera list. And then it also calls for this token that needs to be passed in the exchange where the verified demographics of Deven aren't able to be tampered with, because what they're trying to avoid is somebody identity proofs, but then you're querying for somebody else's data. So they're really trying to limit the concept of bad actors trying to get their data and abusing the networks. That's a whole nother topic, and I'm not going to go into it right now. And then it also calls for something called AAL, which is, in my mind, almost like an MFA workflow that ties the IAL2 event to an MFA type workflow. What we talked about on the stage is this is great. There's an implementation guide update, but when the implementation guide was approved by the steering committee, something that came up on the steering committee that day was that there should be a pilot that goes along with this IG update. And unfortunately for this pilot, very few responding gateways have showed up. The only responding gateway that showed up at first was CRISP, which is an HIE that represents multiple states, and they were looking to, provide patients access to their data because they're mandated under Cures Act as an actor, as a state HIE, which you can listen to past podcasts, and Deven can chime in about this. And they're here to participate in the pilot. Health Gorilla has also said that they're going to participate as a responding gateway. But the problem that I called out on stage at the Sequoia Project was, that's great that HIE-like or HIE organizations have said that they're going to respond for their patient populations, but where are the EHR vendors who have been participating in Carequality since its start and to present date, saying, hey, we're going to participate in this pilot, especially in light of the fact that TEFCA requires patient requests. So if you want to prepare for TEFCA, you should be participating in this pilot to prove it out in the Carequality framework, so that for the future go live date, which we're going to talk about, I would expect any QHIN and any participating EHR to whatever QHIN they choose to be supporting this pilot and testing it with a small group of trusted partners to say, hey, is this working? This is not working. Because what I would hate to see is a spec being adopted for TEFCA that really hasn't been proven out at all within a small group or a group at scale to see, does this work? Because my biggest concern is that the IAL2 spec and AL spec with the token that was pushed into the IG was done with such a small group of people and hasn't really had that kind of large scale influence to say this is actually scalable or not scalable. And it also, there's a lot of other downfalls, but I'm not going to go into all of that. But that was basically the spiciness of the panel. And I'm sure Health Gorilla can provide a link to the original panel so you can watch it for yourself.
They probably can, assuming that Carequality and Sequoia have
I haven't heard that they've posted them yet, but
so yeah. For editors, you know where to find it.
Fair enough. So so I may betray my own ignorance here, in which case I've got three smarter people who can correct me. But there is a difference between what has been proposed for TEFCA and what the Carequality guide update was that you were discussing at that panel, correct?
I think my biggest concern always is, I think that the RCE people working on what TEFCA looks like in the swirl committees are always kind of looking at what's happening at Carequality as just an example of what could be done at scale. So what I'm concerned about is something that is kind of are still creating barriers for consumers to get their data out of a group of people who've never actually empowered consumers to get their data. And that's not pointing my fingers at the EHR vendors. That's literally the people sitting in those committees being like, this is my opinion on what the standard should look like. These are non-representatives of the EHR. These are usually people just who live and breathe Interop and maybe privacy and security. And there are a lot of failures around the OAuth workflow, just in adoption. And there's already going to be a lot of barriers to adoption with the IL2 workflow, because a consumer has to be able to identity proof successfully. And then those verified demographics have to be used for a patient match. So there's always the next part of failures. Is there a match to the patient within that network or HIE or QHIN, right? So there's no guarantee a consumer is going to get back their data. So the more barriers you put in that IL2 workflow, the more there's going to be a drop off in the consumer being able to actually query for their data and get records back, as opposed to when a covered entity to covered entity exchange happens. I mean, it's just, we're seeing the amount of records at scale being exchanged between covered entities. You should see the same amount of adoption for consumers to get their data if they wanted to.
And Dave, to your point, my understanding as well is that the IG that we put through Carequality is in fact different than the requirements in the QHIN technical framework for the IAS queries.
What's the difference?
I think the difference is the AL2. I do not believe that the TEFCA IAS requires AL2, that was included in Carequality. That's my understanding.
Yeah, this is what I concerned in the committees leading up to the recommendation to the steering committee prior to approval is when you're tying an AAL2 event to an IAL2 event, which is based off NIST 6300 guidelines that came out a couple of years ago now, I think 2017, 2018, is that one, you're saying that me, OneRecord, by a Milliman IntelliScript, has to contract with a vendor for 2 net new services, so 2 pricing models or bundles that I have to then adopt and invest into my application. And I haven't even proven at scale that this is going to work. How about we just start with IL2 and then we layer in the AL?
And I think that's the path. I think that's the path we're going to take with TEFCA. That's my understanding.
And then my other issue.
Well, and go ahead, Jen.
My other issue was with the token. So the token was there for security reasons, which I understood, but then there's liberties taken by the vendors on how long the token will exist for. And that's going to be by vendor, their choice on the token expiration. So we're already adding in these 2 net new requirements. And by adding in these 2 net new requirements, we're already creating a friction for something that doesn't even have, there's nobody responding to patient access. So why don't we just get a couple of people to respond in a closed pilot? Because it's not like anyone can just join the pilot. You have to be a current implementer of Carequality. That means you have to have signed the trust framework. I am really on my soapbox. I'm coming down now. It's all you, Deven.
Well, I really appreciate the details on this because I wasn't able to go to San Diego. And so I kind of missed all of this. And I love that it was spicy because at different occasions, I myself have said, although not nearly in that level of really good detail, we are piling up the requirements so high for this that we're making it really hard for anybody to be able to do this. And on the one level, there's sort of like the scariness of this for the data sources that are connected into these networks. These are not HIPAA covered entities. How do we know the patient hasn't been spoofed? But just to go through an IAL2 identity proofing process is itself not an easy thing.
No,
we have pretty considerable drop off for patients to be able to do that. We do the subsequent, sort of something that you have, right? Something that is sent to your phone, like a code, and then you put it back. It's not certified, that portion. So under, the current specs, we can't use it. We would have to find another solution for that piece in order to essentially have something certified that frankly is an interaction that happens on the internet every day, where people prove who they are in terms of something that is sent to something that you have, your cell phone. So people are getting wrapped around the axle on this stuff and wedded to solutions that I totally agree with you have not been tested as to whether they work. And there's no required response back yet.
And there's one more piece to this. Also, the requirements to add this, a lot of the implementers on Carequality have said, I don't necessarily need this. So I might not even, you could query me and send me all of this, and I might not require you to send it. So it's saying half the organizations have to build it and have this huge barrier. And then the other half is saying, yeah, I want it. And okay, maybe it's not half. I'm messing up my pie. But half has to do it. And then the other side, there's some people who will require it and some people who won't. So there's not even consistency on the responding side. So that means you'll have certain vendors who say, you must send this to me. And the other vendors say, we don't care about that. And that creates all this inconsistency where we have a higher lift to build. And the other side is choosing at what investment they want to build to. And they're not even responding. So to me, it's too early to implement something like this. One more thing
go ahead.
Is this ties back to fire at scale. So we're already seeing in the open developer ecosystem with the OAuth workflow, a lot of interpretation around what does patient authorization mean. So we're seeing with the much smaller niche EHRs, this concept of patient authorization means a patient must go to their provider, get their provider to authorize the third-party app before the third-party app can go through, receive a client credential and secret in order to just present the authorization screen, which is essentially username and password, in their application for a user to go through that three-legged OAuth workflow where a token is being exchanged and there's several tokens being exchanged. So for me, I'm already seeing just a barrier with an OAuth workflow that is mandated under law. It has very specific requirements. It's built into the ONC certification G10 updates. And then we have this very loose requirement that isn't built into law and that is, decided by committee. And it's supposed to be the bedrock for, the future of like national exchange. I don't think so. It's not baked for me to really get behind it. Soapbox done.
I was just going to say,
Yeah.
despite all of that and all of these challenges that we've been facing for years, my understanding, and you mentioned CRISP, in talking to the folks from CRISP, is that they are ready today to respond to Carequality patient queries.
And I'm most optimistic around HIEs doing this. And I called this out on stage. It has to do with Deven's work and Citizen/Invitae's work around educating HIEs on their responsibility under the law, under Cures Act, and being actors as information blockers. So I think HIEs are way more primed to actually be responding gateways. However, most of the HIEs are not participants of Carequality, they're participants of eHealth Exchange. So that means that HIEs have to sign up to participate on Carequality to be part of this pilot, or they have to allow, I don't know, Deven, are you acting as a gateway in this pilot? I don't think I ever asked that question.
I don't think so. I mean, I think there were some readiness issues from a tech side on our end that we weren't necessarily going to make it from a timing perspective, but we were definitely, depending on how long it lasts, could end up, still participating because we're very interested, obviously, in helping to facilitate all of this.
And as a developer, it would actually be easier for me to just work directly with Deven outside of Carequality and connect to the gateway her Cures Act gateway for the HIEs that she signed up, or connect directly to CRISP, or connect directly to Health Gorilla, right? So there's a lot of what I consider investment and technical investment or technical infrastructure that I need to invest in order to participate in the pilot that is to a very specific spec to what we started this, Stephen, might not make it into TEFCA. That is why I was spicy on the panel.
Yeah, and then the other thing that I was going to add, Jen, is looking ahead to TEFCA, and it's the last bit of November. Mickey and company continue to say that they think TEFCA is going to be going live next month, and we know that individual access service is a required purpose of query and a required response, at least on the part of the QHINs. So the idea being that we have the opportunity to see what happens with IAS once TEFCA goes live.
Yeah.
Hey, Stephen, let's go ahead. Go ahead, Deven.
Well, I was going to say, unless something has changed, and it very well may have, that I missed a development. My understanding is that the TEFCA rollout for individual access is a facilitated FHIR query. So you don't get data back, or a non-facilitated, non-brokered, you get FHIR endpoints that you can then connect to. So it's almost like just record locator.
And the FHIR roadmap are two separate things.
I think we should dive into this because there's a lot of confusion around this.
Yeah, I mean, I get that the FHIR roadmap is a separate thing, but for a while, Mickey was talking about how he did not see how individual access would work in TEFCA initially without running it back through the portals, and that what would be delivered to apps and through TEFCA would be, oh, here are the FHIR endpoints for all the data that you need to search for your patient. Now go connect to all of them separately.
I think, Deven, this is how I've interpreted what you're talking about, is that there is a gray area in the last version of TEFCA that allows for, the QHINs are going to implement the ability for individual access services to their participants, but then participants could potentially opt out of responding. And so I think, and I don't want to put words in the government's mouth, but I think what you just said is the assumption is, hey, you can support individual access via the Fire at Scale or
Got
Fire
it.
roadmap via an OAuth workflow, which to me is just like, well, why would you join a QHIN and do all that when you can do it in the open developer ecosystem? Because of so many other reasons, right? But it's really, you know, and this is actually kind of cool. What you don't know beyond the patent is there was a patient access breakout, and a big group showed up for the patient access breakout. And there was a big discussion that I was a little in and out of because we were supporting a puppy playtime. So I was more excited about the puppies, unfortunately, than but it was really cute. But the thing that was kind of coming up, what I heard in that patient access breakout is, yes, it's going to come down to the participant level. So participants who join a QN who need to respond to patient requests, covered entities, it's going to be the same thing that you're experiencing with HIEs. Is my state or local policy preventing me from doing it? Or do I find under the 7 exceptions a reason to say I can't do this? Security, whatever it is. And so I think that's going to really tell the future of this. I don't know how much of the provider penalties that are proposed will account for this kind of workflow because I haven't read it, but like future rulemaking should probably take into account provider penalties plus TEFCA, unless that just doesn't happen and it's just going to be Fire and OAuth and we live with portalitis and for the next 10 years, and we won't even have iPhones in the future because we're going to go back to these like little beeper device things and no more screens. And then I don't know.
You made a good point.
So,
Jen.
well, sorry, hang on, Stephen. There's a lot to unpack there, but I do want to circle back to one thing. I think we were mixing two concepts there. We were mixing, I think, the technical mechanism
Right.
/ standard through which an IAS query would occur with the policy elements around whether it was required to be responded to. So when hopefully we all are live on TEFCA here and we can drop the candidate from the candidate QHIN phraseology that we use, the expectation would be that we as a QHIN, Health Gorilla, for example, still a candidate QHIN today, but once a QHIN would have to support our participants in responding to IAS queries via the IHE protocols. So Carequality style demographics queries, document exchange, just in support of IAS, not treatment. And then there's a question there as to, okay, to Jennifer's point, what additional wrinkles might there be there in terms of folks' interpretation of states and local policies and the information blocking exceptions. But then there's a second question of, okay, does this change once the Fire roadmap, once we're further down the Fire roadmap and we have Fire in the TEFCA ecosystem? This isn't limited to IAS, but I agree with you, Deven. I think we are more likely to have that sort of record locator style first, is the sense that I have, which, to be clear, I actually think does add value in terms of having the QHIN ecosystem point out to you where records reside, and then you can, and by the way, here's the URLs at which you can go grab the Fire resources.
You still need to authenticate against multiple Fire servers.
Yes, and I was not to split hairs, but I was speaking there a little more generally, including for treatment purposes and payment and operations, where Fire would be used in those modes as well.
For patient purposes, you would still have to authenticate. For what Dave just touched upon, covered entity to covered entity exchange, you would have a way to use an RLS to locate the Fire servers and that kind of OAuth exchange, whether it's a 2-legged OAuth exchange or a 3-legged OAuth exchange. 3-legged OAuth exchange is going to be the patient workflow. The other two are where there's not a consumer input. But I still think that we are in the early innings, and I'm hoping the more people talk about this kind of stuff in detail, like there's very few people in the country who really know this stuff as well as we do, that the conversations internally and people who decide to be participants of QHINs really think about how do they want to support their patient and member populations. And to me, it's a bad PR move to be building the cellular networks of healthcare and you don't let consumers on the networks.
So Jen,
yeah, go ahead,
if I may, I was trying to get back to a point you made earlier, which is that it seems that the lowest hanging fruit in terms of finding responders to the IAS queries may be the HIEs themselves, based on the work that Deven and others have done. And as we said, Chris, a major, very successful, large HIE, has already really stepped up to the plate with regard to the Carequality patient queries, and again, I believe today is actually ready to respond if they can get any, fitting the IG with the IL2, the AL2. But there are a number of QHIN candidates that we hope will be QHINs in the coming month that represent HIEs. You mentioned eHealth Exchange, Kanza, Health Gorilla, all have HIEs as network participants, and all of whom could, theoretically make those HIE participants available and able to respond to IAS queries. So to me, I see that as the greatest opportunity in early days of QHIN IAS exchange, before we get to FHIR, before we do, OAuth on FHIR, to if we have willing HIEs who are trying to meet their obligations as information blocking actors to make that data available via a TEFCA IAS query.
Deven, were you shaking your head or making your hair look good?
I was just thinking of a couple of things. One is that we have built a completely different trust model in the gateway that has nothing to do with the exchange of tokens or anything of that nature. We do require, there's a set of agreements. It's very customary to how HIEs build their infrastructure for exchange today, which is based on you sign an agreement, you agree to abide by the rules. If you don't abide by the rules, you can get kicked out of the network. But it's, we vet every app to make sure that they have a process in place to identity proof, at least identity proof that meets the elements of IAL2, that they get consent from their users in some way to query for their records, so that the patient isn't surprised to see information in their account that they didn't necessarily go tell that app to go get. And then the third thing is, signing agreements to kind of abide by the rules around, sort of whether there are traffic limitations or things of that nature. So there's a vetting process associated with that. Each of the HIEs that signs up to the gateway is on board with that as a methodology for exchange. And frankly, it's just much simpler and is in the process of being, tested in the wild today. So while there is this sort of opportunity under both TEFCA and Carequality for HIEs to exchange that way, and that's definitely the way that CRISP has decided to go, there are very different models being pursued for how this happens. And I think it really begs the question about what's the best way to facilitate the trust that's needed in order for the information to flow without all these hurdles. We've sort of built this kind of technical infrastructure in the Carequality spec that, frankly, again, as Jennifer pointed out, has not been tested yet, and frankly may be really difficult, when there are other ways to get at this in terms of sort of vetting the participants in a way that doesn't allow for, I don't know any other way, to interlopers or spoofers or that you have trusted people on all sides of the transaction that have been through some sort of vetting. It's something that we resisted for a while on the app side in terms of you shouldn't be able to make a judgment call about whether an app can connect into your FHIR APIs if they've otherwise met all of the specs. But for this type of network exchange where we're not relying on OAuth and the FHIR APIs, we just don't have the same kind of sort of trusted infrastructure for this And yet we're assuming that we can get this done through a set of technical obstacles that I've always thought, like, first of all, it seemed like it was forever being added to in terms of sort of what was expected. And second of all, is untested.
I do want to say one
We
thing.
get data every day from health information management departments based mostly on our reputation and the fact that we ID proof people. That's it. And we get a lot of data for our users. It doesn't have to be this hard.
I think that's an important point that Devin's making, is like, when I said that there was a new implementation guide out, like, Dave, technically there's always been an implementation guide in Carequality to support patient access. I called this out on stage, and a nice gentleman named Eric Heflin wrote the original spec. It's always been there. It's just people don't respond. And to what Devin's saying is there's this much higher level of trust that people who want to participate in Carequality have to. It's not even trust. The level, I don't even know how to explain it. I don't have a word for it. I don't like
Well,
it.
it isn't even a lack of trust, I don't think. It's I'll maybe say one of the, oops, sorry.
It's the cost of the liability. It's the level of risk that organizations who are responding are willing to take on, or if they expose the wrong data to a non-covered entity through a third-party application. That is what we are talking about. And I understand that organizations do not want that risk. And that is something I won't point fingers at, because that is a big deal. And I don't want to see healthcare organizations shut down, because we need healthcare organizations in this country. We need doctors. We do not want organizations to have those kinds of risks, but there has to be some sort of way for consumers to get their data. And if it's through Deven, then she's the vehicle.
Well, and I think
whether
whether Deven has to single-handedly solve this problem or not is maybe a different story. But I think there's a fascinating angle to all of this that we've kind of touched on, but haven't delved all the way into, which is the role of HIEs. And it's just so interesting because, back in the very early days of Carequality, HIEs were the ones that were very hesitant. And they were the ones who were kind of holding back and not quite sure what was going on. And now it's like the script has flipped entirely. HIEs are the ones that are out there, pushing the boundaries and really doing a lot of good to advance interoperability. And it's the EHR vendors who had originally started the sharing through Carequality, who are in some cases, and Jen, you look like you disagree, but are the ones who are more of an obstacle.
The HIEs were the only ones who allowed us. We did Carequality, then Comwell, and then we integrated to a Rio within New York, and that they were the only implementation that we did prior to our FHIR integrations that allowed us to do an identity proofing workflow, query, and pull back data, and it was successful. In my personal OneRecord, I have records from my health system that I was able to pull from one of the Rios in New York. For me at the time, it was a question of cost. I would have to integrate to so many HIEs, and I figured how much each of those costs would be. And just going through the contracting, the management, like, I wanted to sign one contract. I wanted to connect to one network, and that wasn't an option. The difference with FHIR is FHIR was free, and there was a law behind, and I could move quickly. So for me, it was always a question of time and speed and cost, right?
But maybe those HIEs enabled through TEFCA connectivity really are going to become those health data utilities that can support individual access.
Yeah, I do. I agree.
I don't think it's published yet, but Civitas, has been collaborating with ONC and UCSF, and then they did a recent survey of their participants. And, I heard about that this week, and a lot more HIEs are willing to say in a survey that they're planning to connect to TEFCA than we heard even at the Civitas meeting a few months ago. That meeting, I think in triggered a lot of discussion and a lot of awareness that this is not an either or, you know, the HDU model, the national network and framework model, that these are going to come together, you know. And again, maybe that's my Pollyanna speaking here, but I think that's what we're going to see, that we're going to see individuals being able to query the HIEs for their data and leveraging the TEFCA framework and directory to be able to find that.
I think to what Dave's saying and to what Steven's saying is, I also heard similar things at Civitas, but Dave, to back in the day, like Carequality kind of looks like a competitor to HIEs, so that's probably a reason why HIEs are kind of a little skeptical of Carequality.
Oh, no, that's absolutely completely fair. I wasn't saying I didn't understand where they were coming from at the time. I did understand where they were coming from at the time. You know, I thought then, and I think now, that there's a path for HIEs to leverage, whether it's Carequality or TEFCA, as a big part of a value proposition for their members. Oh, sorry, go ahead.
But I'm excited about HIEs participating, whether patient access or TEFCA or whatever, is that HIEs represent local, right? So there are going to be physicians represented in HIEs that, hey, I don't think their FHIR APIs are operational. They might have certified via their EHR, but is that a really operational API? Is it ready for me to call it via the OAuth workflow? Probably not, because that's what I've seen in the market so far. And sometimes, this is what I don't know, and I would love somebody to answer this. Are there providers represented in state HIEs that are using non-certified technology that you can actually get, I can get my data from, right? Like my provider just got an EHR last year. I know. So is my data in that state HIE? I'm super curious to see that. This is only things that I think about.
But what you're saying is, for some of those smaller, you know, less well-funded providers, that data, they could be pouring that into the HIE. It could be accessible there, even though you couldn't get it through a direct query of their EHR.
Yeah, like, because what I found is a lot of the EHR vendors and I'm talking about the smaller niche specialty EHRs, they certified, but
it doesn't mean anything's actually available.
Exactly, it doesn't work. And also the question of how they mapped FHIR is two things. It's a standard and it's content, right? Did they properly map their data to US CDI to be able to be called via that FHIR API? These are all the things that are going to unravel over the next couple of years. Very exciting.
One thing, I'm sorry, Jennifer, I didn't mean to interrupt you. One thing that does occur to me, so, what are the motivations for HIEs to come to sort of really be excited and enthusiastic about connecting to patients? I think there are multiple motivations. One being they are a little bit closer to their communities and do see themselves as health data utilities. So this is another sort of piece of that role. In some cases, they're under state expectations to share data with patients. That was certainly true in New York when the Shiny adopted a set of policies around patient access. But information blocking is definitely playing a role. For a long time, there were just rules and there was no, enforcement rule. Now there's an enforcement rule. They're not the only ones on the hook. The other actor covered by the same set of penalties is certified EHRs. So, which frankly have both an HIE component to them with respect to the network services that they provide to their customers, as well as their role as a certified EHR vendor. And I think that if they think that their information blocking obligations stop at offering the FHIR API, I don't read the rule that way.
I want to circle back to that, but credit where due. I did want to make this point earlier. I did learn something at the conference last week and a half, whatever it was. That Commonwealth, for example, stated that they were now seeing, I think, roughly 18%, which is not super high, but is higher than I thought it was. in
Meditech.
terms of their response rates. And a big part of that, I think, is our friends at Meditech, actually, who have in fact rolled out responses in Commonwealth to patient queries. So credit where due to Meditech on that front, and they may not be the only ones in Commonwealth.
It's mostly Meditech. Meditech makes up the bulk of that number, so go Meditech. They also, their Fire APIs work as expected, which is great. So I think Meditech gets a gold star on effort. They make up the bulk of that percentage.
And what they're doing, just so I'm clear, is a patient can query Meditech using Fire queries? No.
Oh,
Well, they can do that too, presumably. But they will also respond to a Commonwealth query, just as you would do for treatment in Commonwealth, but they will respond for IAS as well, or for whatever Commonwealth calls it, but IAS essentially as well.
It's a document-based query. They just flipped it on in the management portal. They will respond, because what happens right now is when you query, you'll get back in the code. It'll be like purpose of, yeah, I can actually see it because I've seen this in the code. It will say, request denied, purpose of use. So like for everybody else, you're going to see in the code, request denied, purpose of use, patient request. In theirs, when you query, you're going to get documents back because they've enabled it. Like that is literally light switch. Like just flip the switch. Let's do it.
And they have IAS providers on the Commonwealth network that are sending those requests.
Well, Commonwealth, because I worked on this committee to approve it, Change Healthcare, is, the spec for, what they wanted from an IL2 vendor influenced what came over to Carequality as well. So basically, if you, are a Commonwealth member and there's some contractual elements to this, but you've signed the documents and you're going to query for patient requests, and you have an IL2 vendor, and you've done the underlying service provider has certified it and said, yeah, this looks good. You can query for patient request, and Meditech is responding. And but then you still have
the IL2 vendors. The IAS vendors themselves are Commonwealth network participants.
Yeah, there's just one thing here is the person has to be enrolled in the Commonwealth network. So like Jennifer Blumenthal, went to a Meditech site, and that Meditech site enrolled me into Commonwealth. So even though that Meditech site is participating, if my site didn't enroll me, they're not going to get a match because I'm not enrolled in the Commonwealth network. There's this whole linking thing, which is going to change as they move to being a QHIN. But so there is still that other variable, which not a lot of people talk about, because there's a difference between the site being enabled and then the person being enrolled, which is different from how Carequality works, because there's no underlying infrastructure there. And so it's more of just, a directory and a framework for how to exchange data.
But if I, as a patient, went to OneRecord, set up an account for myself, OneRecord is a Commonwealth participant, can I send, and if I've got data over at Meditech, as a OneRecord customer, I can send a query and expect to get data back from Meditech into my OneRecord?
If you were enrolled by that site. So like, it's very similar to HIEs. Like in New York, there's all this paperwork that you have to sign on the clipboard that says, hey, can we opt you into, HealthX or into Rochester Rio? So if you didn't do that, or whatever the policies there are for,
so there's an opt-in at the site, at the
so that's the only variable is if you're not enrolled in Commonwealth, then the data still might not be available. So there's always, no matter the data source, there are these variables. So whenever somebody says they've solved interoperability and there's a silver bullet, I'm like, liar.
So what is the 18%?
Anybody who says that has never tried, yeah.
What's the numerator denominator on that 18% then?
Of the patients enrolled? I don't know if I've ever looked at it. I'm not sure they track that. I'd have to go ask Commonwealth.
No, I meant to say, though, that Dave, you said that Commonwealth said there was an 18% response rate.
Well, response rate, let's be careful. I think 18% of their Pen, share,
It's
will
like,
respond.
it's whatever the denominator, like, I'm just making it up. Let's say it's like 50,000 sites. That's not the number. Then that whatever the meta text sites are is the numerator.
Okay, got it.
The
Yeah,
50,000 isn't right. I don't, somebody Google it off the website right now. I can't remember off the top of my head. I've told these numbers.
But I think, you know, if you think about that from Commonwealth alone, and then you think about where in some geographies such as Maryland and other places where CRISP operates, and you know, others like Kanza who are similarly advanced, the response rates for patients may for document queries, and kind of where we always try to, we say like we'd love to get patients parity with what we have in the treatment realm. We're not there, but I think we're closer than we thought maybe we were. At least once some of these HIEs are fully online, and maybe not all of them are fully online yet.
I think coverage wise, like if I would make a bet that this is still going to be a very low success rate for an individual to pick an app of their choice and get their data, because I can just think about how many unique FHIR endpoints we have, and you know what that represents from a coverage perspective versus what's represented in the current responding gateways, whether Carequality or Commonwealth. So like it's still going to be a really high failure rate when you think about they have to make it through identity proofing, and then either the Carequality has to have responding gateways, sites that are responding, or Commonwealth has to have responding gateways plus patient enrolled, right? So where we are today is where I wish we were in 2016. So great for anyone who's just entering into this. You're entering at the right moment. From a coverage perspective, like if we had COVID again and you needed to get your vaccination data, we haven't really moved the needle.
Fair enough.
I'm a harsh critic. I don't want to sugarcoat things. I want people to know the reality of the world we live in.
Yeah.
And that should motivate people to do better.
No, I exactly.
Agree.
I don't want to sugarcoat it either. All right, let's we mentioned information blocking disincentives. I think Deven, you mentioned this in passing. Can you elaborate a little bit on what has come out recently, and how we think that's going to complement the OIG penalties, how it might further the crusade against information blocking?
Well, we had, unless you've been under a rock for the past few weeks, you know that the Department of Health and Human Services released their proposed rules for for providers who are found to be information blocking, who get referred for appropriate disincentives. Like, what do those disincentives look like? HHS proposed it. This was a rule that ONC wrote, but with the cooperation of the Centers for Medicare and Medicaid Services, as those payment incentives really come out of that office agency within HHS. ONC doesn't really have any penalty authority around disincentives for providers. So, there was a really good summary of this that was provided at the Health Information Technology Advisory Committee that Stephen and I both sit on. And so for a lot of those details, I would refer folks to that recording and the slide decks that were shared there, because it's absolutely fantastic. But in a nutshell, essentially, they have tied the disincentives to existing interoperability payment incentive programs, as well as accountable care organizations too. But that's a subset of the providers who are covered by the information blocking rules. A lot of questions that have come up about just how effective those disincentives are going to be. So, if we can go into some detail if you want. There's a lot to be said here, and we're in an open public comment period, so it's worth commenting on them. It's a nice, maybe that's not the word I want. It's a start, right? We didn't have anything at all for a while. Now we have these to comment on, it leaves huge swaths of providers who are subject to the information blocking rules out. It's not clear that that's terribly fair to those who are in. So it's a little bit of a job half done, but you got to start somewhere.
Yeah, I really
So-
agree, Deven, that it is a good start. But as you say, I mean, it uses the Promoting Interoperability program, where basically if you're a provider and you're found to be an information blocker and you would otherwise be getting a Promoting Interoperability incentive, that you would lose that. You would not be considered a meaningful EHR user for the calendar year that you were found to be information blocking. Then there's the MIPS quality payment program, so that the eligible clinician would have a disincentive in that program as well. And then the third one was the Medicare Shared Savings Program, where the providers found not to be meaningful users would lose out in that one as well. So those were the three major disincentives that were proposed. Obviously, we're running out of time here, and I think it would be good to come back. The next time we meet. Actually, the next time we meet, we are going to have a special guest who is also part of the high tech, and I'm sure we'll works at a provider organization, and we'll have plenty to say about that. I don't know, Dave, if you want to spill the beans on that.
Who's our special guest?
Stephen, I think you and Jana are ahead of me.
I'm going to say it. Yeah, we're expecting to have Erin Mary join us in Deven's place in January.
Oh, yay!
Cool.
Yeah.
Oh,
yeah. I think that'll be really interesting. I'll definitely be looking at the recording.
excellent. Well, we'll have at least one viewer. But thanks everyone, and there's so much obviously that we can cover. We can say more about information blocking. Obviously, we can talk about California's efforts in going a somewhat different direction than the federal government has gone, and obviously we'll know more about TEFCA Worlds by the time we next convene as well. So looking forward to that.
I like that.
And,
I like that expression. It sounds like Western world or some sort of futuristic sci-fi place. Anyway,
California things again? The California Q-hens, what are they called?
Q-Hios.
And they're not really the same as Q-hens.
They are not the same as Q-hens, but we could.
Ios and HIEs. Oh my! I just wanted to say that.
All right. With that, thanks as always to Deven, Jennifer, and Stephen, and we will see you next time. Take care.